morning, everybody. I'm James Pilant, and I'm moderating this today. This is a video conference on suicide prevention. We have people from all across the United States, and our first speaker is Sally C. Curtin, and she gave me a little bio here to read. Sally Curtin earned a BS in mathematics from North Carolina. I'm James Pilant, and I'm moderating this today. From North Carolina State University and an MA for demography from Georgetown University. We have people from all across the United States. She began her federal career in 1986 at the U.S. Bureau of Census. A little bio here to read. Sally Curtin earned a BS in mathematics from North Carolina. I'm James Pilant, and I'm moderating. Apparently I get to myself without intending to. Her career at the National Center for Health Statistics, the Centers for Control and Direction, began in 1988. She's worked over the years on marriage, birth, and mortality data. Her recent research on trends in suicide deaths, in adolescents and young adults. So without further ado, Sally Curtin.
Good morning, everyone. Thank you for the introduction. And it is a pleasure to be here this morning to present findings from some of my recent work on suicide at the National Center for Health Statistics. And we are part of the CDC. So I'm providing an overview of trends over the last 20 years. And I'm also including some data for Oklahoma, so you can see how that state rates with the US. And let me start by saying that all the trends you're going to see are pre-pandemic. The latest, the data go through are 2019, and suicide rates nationally during the pandemic are still being compiled. So anyway, I have about 30 slides to get through, so I'm going to be throwing a lot of data at you over the next 15 minutes. Hopefully, it all taken together will paint a compelling picture of suicide trends in the US, and I will summarize at the end. So without further ado, let me share my screen. And I will summarize at the end. So without further ado, let me share my screen. And so here are the recent reports. And by recent, I mean published over the last 2 years. And some of the topics featured are age-adjusted death rates, suicide by method, urban-rural differences in suicide trends, rates by race and ethnicity. And I will summarize at the end. Without further ado, let me share my screen. And so here are the recent reports. So let me give you a brief introduction to our data. All the findings of the topics are based on data from the National Vital Statistics System, which come from the statistical information for death filed in the 50 states. Rates by race. And I will summarize at the end. Without further ado, let me share my screen. Usually the next of kin. And the underlying cause of death is supplied by physicians, medical examiners. Causes of death are the International Classification of Diseases, 10th edition. And here are the suicide codes here in bold. The outcome measures represented today are suicide rates, which is the number of deaths per 100,000 population. And oftentimes this rate is 500,000 population. We do the age adjustment to neutralize the effect that aging in the population has on the death rate. So this is the first report that I will present findings from. This report was published just last month on suicide mortality in the US. And this has become a standard yearly publication with the trends updated with the most recent data each year. Okay, this is the first figure in the report, and it shows the total age-adjusted suicide rates and in total and by sex. And you can see that for the most part, the trend has been upward, both in total and for males and females. The very last year of this trend, 2019, has a slight downturn, which was statistically significant. In total, the rate increased about 35% from 1999 to 2018, before declining by 2% in 2019. There were similar trends for both males and females, although the rate you can see for males is much higher. It's about 3 to 4 times higher than for females. However, the difference between males and females narrowed slightly over the period as females had greater average annual percentage increases. In this slide, I'm adding in some Oklahoma data, and the Oklahoma data are the dashed lines to compare with US totals, which are the solid lines. And you can see that the Oklahoma suicide rates are almost always above the US rates. And there's more variability in the Oklahoma rates due to smaller numbers, but it is the same generally upward trend as with the US. This is a map which you can actually access on our website. And these are age-adjusted suicide rates by state. The states with the highest suicide rates, which are sort of the dark purple, are Alaska, Montana, and Wyoming. And the next highest states are those in maroon color, and you can see that Oklahoma is one of those states. Oklahoma has the 8th highest rate of all states in the US, nearly 50% higher than the US rate in 2019. So I just wanted to give you an idea of where Oklahoma ranks in terms of suicide nationally. Okay, now I'm back to US data, and these are rates by age for females. In general, you can see that all age groups trended upward over the period, except for the oldest women aged 75 and over. And that's like, it might be hard to see that line. It's like a grayish green line, second from the bottom at the end. But you can see that rates for some age groups have leveled off recently, and the rate for 25 to 44-year-olds actually declined between 2018 and 2019. Middle-aged women, those aged 45 to 64, had the highest rates throughout the period, although they have leveled off since 2015. And the youngest age group, 10 to 14, has the lowest rate, but it had the greatest percentage increase over the period. And this is a similar graph, except this is for males. And similar to the findings for females, all age groups have generally trended upward over the period. Some of the rates have leveled off recently, and rates for a few age groups declined significantly between 2018 and 2019. But for men, it's the oldest age group, the 75 and over, who have the highest rates. Rates for this age group initially declined from 1999 to 2009 and then increased. So for men, it's the oldest, and just a slide ago, I showed you that for women, the highest rates are middle-aged, 45 to 64. So now I'm back to the females. And this graph is suicide rates by method of suicide. Poisoning deaths, what we think of mostly as drug overdoses, although other types of poisoning, were the leading method for females most years of the period. However, the rate for these types of suicides declined after 2015. In contrast, firearm deaths increased between 2007 and 2016 and then stabilized. The method with the largest percentage increase was the suffocation deaths, and most of these deaths are hangings. And that rate tripled over the period. Thus, here recently, firearms and suffocation replaced poisoning as the leading suicide method for women. Here's the same graph, except for males. And you can see that it paints a bit of a different picture than for females. Firearms are always the leading method and increased between 2006 and 2019. Rates for suffocation deaths, once again, mostly the hangings, had the largest percentage increase, doubling over the period. And similar to the females, suicide rates for poisoning deaths have declined recently. So this graph shows what the method looks like for Oklahoma, and these are rates for the total population, males and females combined. Firearms is the leading method over the period and generally trended upward. The suffocation deaths have the largest percentage increase, while poisoning deaths have appeared to slowly decline. The next report I'll present findings from is one published last summer on urban-rural differences in suicide rates. In terms of the rural classification for our reports, we used a scheme developed by us, by NCHS, and published in this report that I'm showing here on the slide. And classification of urban rural is based on the decedent's county of residence. Every U.S. county or county equivalent is classified based on a combination of the county's 2010 population combined with whether they were classified as being in a metropolitan or micropolitan statistical area according to 2010 OMB standards. And I know this is a very brief general description. More information is available upon request. So using an urban-rural dichotomy of county of residence of the decedent, suicide rates have been increasing in both rural and urban areas, as shown on this graph. Rates in rural areas were higher than urban in 2000, and this difference widened as rates in rural areas increased by 48%, compared with 34% increase in urban areas. So similar trends, but greater increases for rural. Here's the urban-rural dichotomy for Oklahoma. Once again, there's more variability than with the national numbers due to the smaller number of cases. But for the most part, the rural rate was higher than the urban rate, and it did have a greater percentage increase over the period. 60% increase from 2000 to 2019 for rural, compared with the 32% increase for urban. Okay, now I'm back to US data, and this graph also shows the urban-rural dichotomy, but for males and females separately. And you can see both male rates are much higher than the female rates. But for males, the rural rates were higher than urban in 2000, and the difference widened over the period. For females, rates were initially similar for urban and rural areas, but diverged as rural counties had greater increases. Now I'm presenting rates for males only, and this graph shows the urban-rural classifications, but for the three leading methods of suicide. And you can see that firearm deaths for males in rural areas were the highest rates of all groups, and the difference between the urban and rural firearm-involved suicides widened over the period. For suffocation deaths, which are the long dashed lines, it had the largest percentage increase of all methods, and rates in urban and rural areas were initially similar, but then the difference widened with rural rates being higher. And the poisoning deaths, which are the small dotted lines at the bottom, were similar in urban and rural areas, but basically flat over the period. Okay, this is the same graph for females this time. And I know this graph is confusing for now, so just focus on the top line because there's so many lines intersecting each other. Same as for males, it's the females in rural areas with firearm-involved deaths that had the highest suicide rates of all groups. Now, this is the same data as the previous graph, but I'm just showing the firearm rates. And you can see that rural was always higher than urban, but that they did diverge slightly as rural had a higher percentage increase. And these are the suffocation deaths for females by urban rural, and rural was initially slightly lower than urban in 2000, but this rate nearly quadrupled over the period so that it was clearly higher by the end of the period. Okay, now I'm going to show you some findings from a report on suicide rates by race and ethnicity, and this was released in 2019. And this is the graph for females. And you can see our categories for race and ethnicity combined across the bottom. There's non-Hispanic white, non-Hispanic black, Hispanic, non-Hispanic Asian or Pacific Islander, and non-Hispanic American Indian or Alaska Native. And all groups experienced significant increases in rates between the two study periods, 1999 and 2017, except for the non-Hispanic Asian or Pacific Islander. And you can see they did increase, but due to small numbers, it did not reach statistical significance. The highest rate in 2017, as well as the largest percentage increase between the 2 years, was for non-Hispanic American Indian or Alaska Native. Non-Hispanic white females had the second highest rate in 2017, and rates were lowest for non-Hispanic black and Hispanic females. Okay, this is the same graph, but for the males, and similar findings Findings as for the females, all groups experienced significant increases except for non-Hispanic, Asian, or Pacific Islanders. And the rates for non-Hispanic American Indian or Alaska Native were the highest in 2017 and had the largest percentage increase over the period. And non-Hispanic white men had the second highest rate in 2019. And the last report I'm going to show you findings from, this report was specifically on the youngest decedents of suicide, those aged 10 to 24. And this was published last September. And this report focused on suicide rates for young people by state. And this is a graph in the report showing the percentage increase in suicide rates. And there were two study periods, two 3-year averages used, 2007 to 2009 and 2016 to 2018. And I know it's hard to read the state names, but the blue line is the US average. And between those two study periods, less than 10 years, the US suicide rate to young people 10 to 24 increased by about 47%. And the increase was quite broad. 42 states had significant increases between these two periods, ranging from 22% at the top, Maryland, to a more than doubling of the rate in New Hampshire. Okay, this is the same graph, but I'm focusing on the bottom part of it because I want you to see where Oklahoma ranks. Oklahoma was one of the states with the largest percentage increase in youth suicide between the two periods. It increased by about 70%. Okay, so just to summarize, and I know I've thrown a lot of numbers at you, but for the most part, the overall finding with suicide trended upwards over the past few decades, except for right at the end of the period, where it had a slight downturn between 2018 and 2019. And rates increased for most age, race, and ethnicity groups, increased in both rural and urban areas. Rates increased for firearm-related suicides, as well as for suffocation suicides, what we think of as the hangings. And firearms and suicide recently became the leading method for females, replacing poisoning. For the youth, the suicide rate increased nationally 47% in less than 10 years, and this increase was broad, with 42 states having significant increases. And so now I'll summarize the findings for Oklahoma. The rates are higher than the US average, almost 50% higher in 2019. Firearms are the leading method in Oklahoma, although the suffocation deaths had the largest percentage increase. As for the US, rates rose more in rural than urban areas in the last 2 decades. And Oklahoma also had one of the largest percentage increases in youth suicide. So here are links to the reports that presented findings from today. And please reach out if you want more information. And here is my contact information. And thank you for your time and attention. And I believe questions.
Does anyone have any questions for Sally Carton? You can type them in if you'd rather not speak. I have one. I thought the urban-rural divide was astonishing. Why, do you have any suspicion as to why the difference is so wide?
Well, there are a lot of theories about that. I think some of the people coming after me, the prevention specialists, might be able to answer it more fully. But there have been some question on whether access to mental health services might be better in urban areas, and so people who have depression and suicidal thoughts might be able to get better treatment in urban areas. And then there's also some theories that just, the people are just different in general, and perhaps in rural areas than urban in terms of their mindset and how they handle depression. So hopefully others coming after me might be able to answer that, like I said, more fully than I'm able to.
Okay. Well, do you have any closing? Is there anything that you'd like to add?
For me, just, once again, I know I threw a lot of numbers, and but for the most part, it has been steadily increasing. It is encouraging that we did see that 2% drop between 2018 and 2019, although with anything, it might be a blip. We can't read too much from that, especially with the very next year is 2020 COVID. We have to see what happened there. But, the youth, the 47% increase in less than 10 years is certainly troubling. And the increase for the American Indian population, and one thing is we know that on the death certificate, deaths in general to American Indian, the American Indian population are underreported. So we know even though they had the highest rates and the biggest percent increase, it's still underreported. So, and so I know somebody specifically is going to be talking about that population.
Well, one of our observers has asked a question. They want to know why New Hampshire is so high.
Oh, good. I can't comment specifically. I mean, the numbers are, it's a small state and the numbers are smaller for New Hampshire. So sometimes what seems like a huge percentage increase, like number wise, is not that great. I mean, that is one thing about showing rankings is I guess states sort of get, picked on a little bit. But what I was trying to show mostly is that, and the reason why I did the report is I wanted to show that the increase in youth suicide across the US was very broad. 42 states had significant increases. The other 8 states, which I did not mention, had, they all had increases. Nobody had declines. They had increases, but the numbers were small enough that it was not statistically significant. So I think somebody from New Hampshire could probably answer that question better than I could.
Well, I thought you answered it. Well, states with a small population is going to have more volatility.
Right, exactly. And even Oklahoma did, it showed you more volatility in rates.
I have a
Well,
quick
thank you very
question.
much.
For the Oklahoma suicide increase of 70%, what years were those again? I was too busy trying to get my pen and paper.
Well, for the month, it was 2019 for the most part to.
Just 1 year?
No, 1999 to 2019.
Okay, thank you.
I believe your slides are going to be available for anyone doing this, participating in this exercise.
Yes, I believe so. And like I said, if you want more numbers behind it, I hope my contact information will be available. Reach out and send me an email.
So this is not closure. We're never going to see. We're not going to see this data again. It's out there, freely available on the internet as well as with our site and you personally.
Right. Exactly.
Excellent. We are in good shape. Any further questions? Well, thank you very much. I believe we go on to Stephen Wakschal, the Ph.D. in law and our law enforcement expert. Thank you, Sally. You were wonderful.
Thank you, and good morning. I'm going to present a very small, brief overview of a segment of the CONQUER program, which is a suicide intervention and prevention and awareness program for law enforcement professionals. More additional information, contact information is available on the website, which is www.conquersuicide.org. And if we could put up the first slide. While that's happening, I'll just go on and say that there are 3 main concerns when it comes to the current approaches to law enforcement awareness and prevention. The first that we know law enforcement prevention asking the officers to out is much less effective than asking a reach in. Yet the out campaign 10 to persist. The second problem is that the current approach tend to visit what we already know. They tend to focus on issues around investigation, financial difficulties. But when we bring common sense, we realize that these factors are relational, but they're not causal. When it comes to causal, identify the genetics, mental factors that actually underlie suicide. But despite all that, depending which study, anywhere between 40% are not. They're impulsive, and whatever big. So we focus on intervention, self-efficacy, which is making the partner or co-worker more ready, willing, to step in. If we look at some of the risk factors for suicide, some are specific to law enforcement, some are more global, but we look at a cumulative exposure to violence, access to irreversible means, which generally means a weapon, gender, males are more likely to take their lives than females. We look at orientation. Members of the LGBTQ community, suicide, as well as Caucasians have. When it comes to relationships, those who are single have a higher rate, as well as those living with some form of financial stress, including poverty. Some additional risk factors we look at are certain psychiatric disorders, not ones that we would typically associate with suicide, but what we look at is specifically bipolar disorder and specific personality disorders. Other risk factors include serious medical conditions, usually those medical conditions that may have a terminal outcome. Those tend to increase suicide potential. A history of abuse, a family history of mental illness or suicide, various life stressors, and a lack of spirit. Okay, catch up. There we go.
Every time you share the screen, it echoes.
We can go without the slides, I think. It's fine. Additional suicide risk factors for law enforcement, and again, some are global to the general population: alcohol misuse, shift work, not having a consistent shift schedule, sleep deprivation, as well as post-traumatic stress disorder. For law enforcement, investigation is a big factor, because to some law enforcement officers, it represents abandonment by their family. Having an abnormal job. Law enforcement is an abnormal job. What law enforcement officers see in a day, most civilians don't see in a lifetime. Previous attempts or gestures is also a risk factor. Interestingly, if an attempt or a gesture is self-interrupted, the likelihood of repeating it is decreased. And then we look at loss. That gets its own category. And loss we look at in terms of relationship, status. Status, we think of demotion at work, but also promotion at work is a risk factor, because promotion involves loss. It involves loss of friends, of routine, of maybe a work location. Bereavement, as I mentioned, finances, loss of physical health functioning, loss of mental health functioning, problems with cognitive functioning, attention, concentration, memory, focusing, as people get a little bit older. Loss of housing, either due to eviction, fire, divorce, separation, retirement, without a clear path of what to retire into. And we look at termination as a risk factor. So some of the early indicators of suicide, some are more typical: giving away possessions, withdrawing from family, work, friends, and having what we call anhedonia, no longer getting pleasure in activities that used to give us pleasure. Additional early indicators involve the misuse of alcohol and drugs, impulsive and reckless behavior. In the law enforcement community, that often involves not wearing a protective vest, maybe not waiting for backup to arrive, being the first person into the scene, playing with guns, self-mutilating and cutting behavior, and really any noticeable behavior change. We may get a sense that the person is feeling guilty, helpless. They may feel hopeless or sad. They may express these emotions, or we may just sense it. And police officers are very, very good at sensing. It comes with, I think, an innate ability, but also something that is constantly reinforced on the job. Because in reality, a police officer has merely seconds, if that, to assess a situation. So they rely a lot on their senses. Or other early indicators involve, again, either sensed or expressed feelings of loneliness, worthlessness, anger, feeling desperate, or expression of past regrets. What we may notice as an indicator as well is a lack of interest in appearance, a loss in sex interest, a disturbed sleep pattern, a change of appetite and weight, irritability, and any worsening or development of physical health conditions that may have a stress component, asthma, diabetes, weight gain, anything that has a stress component to it. And we may often hear a statement to the effect of, all of my problems will end soon. No one can do anything to help me now. Now I know what they were going through. I just can't take it anymore. I'm a burden to everyone. I can't do anything right, and I just can't think straight anymore. Because very often the suicidal person will have racing thoughts that are jumbled. Typically, police officers, if they do, they are with someone, a partner or coworker, who is at risk for taking their life, there are three general responses that we see. One is termed observational failure. That's where the partner or coworker just misses it. It's either because of a self-absorbed personality, they're preoccupied with their own issues. Observational failure is unintentional, and it's just a basic unawareness of what the person next to them is going through. The other response we see often is rejection. And that's where a partner or a coworker just fails to accept or consider the possibility that their partner or coworker would ever consider taking their life. It's intentional, but there's no malice. And there is a full awareness that the person next to them is struggling with suicide, with thoughts, but they just won't accept that possibility. The third is actually ignoring. And that's where we focus, because we find that many police officers pick up on all those early indicators of suicide, yet they don't do anything about it. They ignore it. Either they're unprepared, they're unwilling, there is an awareness, but it's not with malice, but there is an awareness. And what we try to do again is improve the self-efficacy, making the partner or coworker more ready, willing, and able to step in now that they know what to do. So we look at this lethal equation, which is unbearable pain, and that could be physical and or emotional, a sense of hopelessness that things will never get better, a sense of helplessness that there's nothing the person or anyone else can do to make it better, coupled with loss. And if we have that in place with any noticeable change in behavior, appearance, or emotional state, then we have a suicide potential. So what do we do with that? We look at empathy and acknowledgement. Empathy being the ability to feel what that other person may be feeling and experiencing, and acknowledge their pain. That's what we do. We acknowledge their pain. And we do that through connection. Connection basics, what we know, like I said, 20 to 40% of suicides are impulsive, even within that 20 to 40%, there is still a 20-minute window that we could intervene if given the opportunity. It's also very important to note that if someone is distraught, we can still connect through using some basic listening skills. We want to change the greeting, "How you doing?" to really meaning, "How are you doing?" to show true concern, true empathy and acknowledgement. We start the conversation by using any of those early indicators as an icebreaker. I noticed lately your uniform is not as pressed as it used to be. I notice you haven't been doing your hair the way you usually do. So any of those icebreakers. The reason we connect is to delay, because the research has shown that if someone is considering suicide, if we get them to delay that act, even by minutes, there's a very good chance we're going to have a successful outcome. We don't train the officers to fix the problem or give advice. We just train them to be able to, again, show empathy and be able to offer the resources that the person in need would need. The problem is the suicidal person doesn't see options. They see black and white. The difficulty we find is with traditional police communication. This is the challenge in working with law enforcement. Police definitely usually have rapid fact finding. That's what they do. They want to know the facts. They don't have a lot of time for the fluff. They have to move from job to job to job. They want to solve the problem and they want to solve it quickly. Usually some interruption takes place and the focus is on the officer's agenda. It's not on the person in need. That's traditional. So we need to change that. So we train the officers to, when they do have concerns about somebody who they feel might be at risk, we train them to ask directly about suicide. First thing we do is, we, again, frame with early indicators, and we consider asking them with reference to others to normalize their feelings. For instance, we could say, Officer Joe Smith, he's feeling, I know that he's been feeling down in the dumps. I know that he's been, not really taking care of himself. And a lot of times officers who seem that way have thoughts about taking their life. Are you thinking about taking your life? So we try to normalize it by reference to others. Any response by someone we have a concern about that is not an emphatic no with really convincing reason, we assume is a yes. And again, we go back to that police sense, that sixth sense of trusting the gut. When we talk about asking directly, we ask directly. We don't say, are you thinking about hurting yourself? Because that will generally yield a false response. You ask someone who's suicidal if they're thinking about hurting themselves, their thought process is, no, I'm not thinking about hurting myself. I'm thinking about killing myself. So no, I'm not thinking of hurting myself. So we need to ask directly. We also need to avoid phrases such as, don't tell me you want to kill yourself. Okay, that implies you don't want to hear that, so I won't tell you. We avoid a phrase such as, that's crazy, you don't want to do that. Now the person is already doubting their mental stability, their emotional stability. Now you're confirming. You're saying, that's crazy. That becomes a problem. The idea of, why would you do that? You have so much to live for. The reality is, again, they don't see the options. When someone is suicidal, logic is pretty much absent. Emotion is at a 100% level. So they may not realize they have what to live for. And the sad reality in many cases is they may not actually. We avoid phrases like, what about your wife, your husband, your partner, your family? We don't know at that point if those factors may be contributing to the suicide, to the suicidal ideation. So we avoid questions like that. Once we're in a place where we feel the person is at risk, then we have our response considerations. We think about the lethality of their means. If it's a police officer, we know they have lethality lethal weapons available almost immediately. We look at the mental status. Are they logical? Are they are they coherent? Are they rambling? We see if they're intoxicated. We look at the immediacy of their plan. Do they have a plan? Is it a doable plan? And is it going to be carried out immediately? We look at their support system. If they have a history of alcohol misuse, have they been involved in support groups? Do they have sponsors? Is there family? Is there clergy that could be involved? And we also, before we respond, we look back at those early indicators and we consider the intensity, how strong they are, the duration, how long they've been going on, and the frequency, how often they occur. Based on all these response considerations, we come up with a plan that may or may not be part and parcel of the agency protocol. And I will take any questions. I'm not hearing.
I really enjoyed that presentation. You have a lot of direct knowledge. It was excellent. Thanks.
Thank you.
Let's see.
The overall training, just to add in, is a 5-hour training done live in person. It's a no-cost training. We don't charge any agency or any law enforcement agency or organization for the training.
Do you have any writings on this subject that you'd like to put up and share with us?
It's all on the website, www.conquersuicide.org.
Okay. You have a full caseload now.
Yes.
Even while you're presenting today is a side issue to your regular work.
Correct. I have a full-time private practice that is comprised mostly of law enforcement officers.
Okay.
And their families as well.
Well,
because that's a whole separate population, what it's like to be married to or living with somebody in law enforcement. As well as I have clients who are survivors of suicide, meaning that their spouses or partners took their life, and working with those survivors and their children.
Let me ask you a very generalized question.
Sure.
I noticed from Sally's presentation that suicide is becoming more common across the United States, especially in rural areas. And of course, policemen are a special case. I was actually reading the other day that veterinarians have an increased rate of suicide. Do you have any? What are your observations about the not just police, but the general perception of suicide in the culture?
Well, I think it still remains a very taboo subject. I haven't seen that shift at all. It's still something we don't talk about as much as we should. It's still whispered. Many people who have lost someone to suicide will, not really discuss the way that the person passed away. They'll say they passed away of a heart attack or some illness. They won't get into the suicide discussion because it is considered taboo. This year, interestingly, it's always been where more police officers lose their life to suicide than line of duty events. This year, 2020, that seems to have reversed, where more officers die by line of duty than by suicide, and not really sure why.
Ms. Curtin was telling me that we don't have the data yet for the last year or so. So the effects of the pandemic and the other events that happened over the last year have not been figured in yet.
The data that we get on law enforcement is a little bit of a different tracking. It's by an organization called Blue Help, where families, friends, coworkers reach out to the organization and report. So I'm sure there's still a tremendous amount of underreporting that takes place by that type of process as well. So she's right. The numbers are just not there to make definitive statements.
It seems that a good start would be to start setting up accurate data in some fashion so that we can get an idea of the nature of the problem.
Correct. And my understanding is there is a bill right now. I'm not sure where it is in the process, but there is a bill to ensure accurate reporting
Well,
specific to law enforcement.
we probably need that badly. I want to thank you very much for appearing today and for the really powerful content of your presentation. Thank you so much.
Thank you.
I believe that Dolores Bigfoot, Dr. Bigfoot is next. Is she here? Okay, I see William Durick is here. Would you like to present now?
Hello.
There you are. I'm sorry. I was about to count you out.
Well, I was blocked, so I couldn't turn on, and so finally they allowed me to access.
I'm so sorry. I was looking at your vita at Oklahoma University, and it's amazing. A child psychologist, you're in charge of Native American programs there. You participated in the state and national level on a wide variety of issues. I'm very impressed and a little awed. Would you like to tell us a little about yourself right now?
Certainly. I want to thank Stephen and Sally both for the extensive information that they provided to us and how important it is to have such detailed information. And as we think about the effect of suicide in the lives of many of us, I'm Dolores Sabia Bigfoot. I'm actually of the Caddo Nation of Oklahoma, which is out in Western Oklahoma. And I'm a child psychologist by training. I'm at the University of Oklahoma Health Sciences Center, and I have a couple of different positions that I serve there. I am the director of the Indian Country Child Trauma Center, which provides training and technical assistance to providers, mental health providers in the treatment of child trauma. And then I also, which is related to this presentation, I'm also the director for the Suicide Prevention Resource Center, which is a SAMHSA-funded national training technical assistance center. And as we think about the issues that are affecting our nation and the rates of suicide, then we want to be able to do as much as possible to prevent, to intervene, to provide services that eliminate the risk as much as possible. And so I really appreciate the information that both Sally and Stephen gave about, what is the concerns, why we are concerned about suicide. And I'm also, very happy with Stephen's presentation about what we can actually do and, how far upstream can we intervene as we think about suicide prevention. I am not going to pull up any slides. I also, we kept having that feedback on the echo, and I think that I probably would create havoc on the internet if I tried to do something. I also work with American Indian Alaska Native tribes, and we know that there are 39 tribes in Oklahoma, as well as about 200 other tribal groups that are in Oklahoma. So they don't have their governance in the state. For example, my children are enrolled at Northern Cheyenne. However, Northern Cheyenne from Montana, another very high state for suicide, and but they live here in Oklahoma. So we have the governance of tribes as well as individuals that are tribal members that live within Oklahoma. And I want to talk a little bit about the Suicide Prevention Resource Center. It has an extensive website that allows you to access a variety of information. And so there's a lot of prevention efforts, there's a lot of training, there's a lot of strategic planning, there's the National Action Alliance, there's the Zero Suicide, there's distributions of resources that are available. The efforts to increase lived experience, individuals with lived experience so that they can be part of this prevention effort is also being expanded. So as we consider suicide prevention, then we want to make sure we address those that are at high risk, those that are vulnerable. And I just want to, I can't bring up my slides, but I would like to say that one of the discussions that's going on in our American Indian, Alaska Native cultures is the impact of colonization and the despair and disadvantage that exists within our tribal groups. As we think about, individuals that lack the leverage, the power, the influence to impact how they want their lives to evolve in a positive way, I think many of our disadvantaged communities have been experiencing that for generations. And how do we help shift so that we are more supportive of that understanding of despair? We heard Stephen talk about empathy and being able to be forthright about what is impacting our communities. And so as we think about racism and prejudice and injustice, they truly have a impact on our vulnerable populations. And one of the things within our tribal communities, if we think about it, we have a lot of high-risk individuals. There is the high risk for suicide, the high risk for substance abuse, the high risk for health disparities. And as you consider that pathway, that how did all this come to be, and our American Indian, Alaska Native populations are really an honor-based society. Honor and expressing generosity, being able to recognize the ancestors, recognize the generations going forward, and the things that were taken away that doesn't allow that transmission of that honor meant that shame has taken place, and that shame has replaced that pathway. And so when we think about our Native or Indigenous population, then shame has become that pathway to adulthood. And all the things that contribute to that shame, and all the lack of infrastructure that contribute to health disparities, and all of the disadvantage that comes from not having an economic base, or not having a financial security, or being able to tell the correct history, and having policies and procedures that even currently make it hard to have self-empowerment. So as we think about vulnerable populations, including American Indian and Alaska Natives, there's that whole history. We know about the adverse childhood experiences and how that impacts children. We know about, child welfare and how that tends to be a pathway toward the juvenile justice and delinquency arena, and how that can be a pathway toward prison, and how we see substance abuse as part of that, and how even in Oklahoma we have the highest rate of incarcerated women, and think about their children. So as we consider all of the things, what are the prevention efforts that we can bring in and think about to alleviate some of that despair, some of that depression? How can we help to improve mental health, not only for individuals, but for communities? And so I'm excited about taking the lead for the Suicide Prevention Resource Center, to working with organizations around the country, to working with universities, working with state coordinators, working at national levels, so that we can look more broadly at how we can do prevention efforts and suicide prevention. I appreciate the opportunity to give you this information, and I welcome any questions. Thank you.
I really enjoyed that. Certainly Native Americans face challenges that the different populations in Oklahoma don't. And of course, here we are in Miami, Oklahoma, where this presentation is based. We have 11 tribes based here. So we have some knowledge of the crises that it's dealing in. Of course, from Sally Curtin's slides, we saw that the suicide rate in the Native American population had increased more dramatically than many other groups. Do you have a comment on that?
I think that's where we're seeing a lot of the despair, a lot of the substance abuse, a lot of the inability to have the resources that allow people to thrive. There is a national commission that I'm on. It is the National Commission. It's a Commission for Native Children. That's a bipartisan legislative mandate that was established in 2017. And so we're looking at issues of children and the projection for children. We see that there are, pretty high risk for American Indian, Alaska Native children from the age of 12 to about 24, 27 for suicide completions. And so what is it that creates the conditions where children start thinking about suicide when they're 6 and 7 and 8 years old, so that by the time they get to be 12 and 13, they have refined their activities, and that they get more, that completions can be more, or deaths is more likely as they get older. So I think, looking at childhood trauma, looking at, kinds of supports that communities can provide. And it's also important to note that 70% of our population live off reservation. 70% of our population is in urban, non-reservation areas. So we're in communities, of urban communities and others. And what kind of support networks are there for our tribal members? And do they feel like they have the kinds of resources that allow them to thrive? So
one of our guests has typed a question in asking if you believe that the disappearance of the culture of the Native American is responsible for these suicides.
Well, I think that we can consider that anything that allows us to connect, to have an identity, to have a sense of belonging, and our cultural teachings, when we look at the 39 tribes that exist within Oklahoma, how many of those still retain on a tribal wide basis their tribal culture, their tribal language, provide for tribal events on a regular basis. And so, cultural loss and is a very much a part of that level of despair. And we heard from Stephen, that loss is an important aspect of why people have thoughts of suicide. And the sense of belonging, sense of identity. How many of our Native children have Native names? How many of them know who their grandparents are? How many of those can identify their lineage, which was a common feature, historically, that being able to identify your clan or your band or the society, the family lines that you belong to. So all of those things, that cultural loss is there, as well as land loss, as well as family loss. So there's overlaying layers that are very impactful for our tribal communities, as well as non-tribal communities. And when we think about poverty, we think about children with disabilities. We think about children who don't have access to food. So there's a lot of things that can cause a sense of loss and a sense of not being important to someone.
As an attorney, I can't help but observe that the tribes have been given more authority to create their own law enforcement over the last few years. The Supreme Court has come down on the side of Native American land rights in a substantial way. This may be a golden era in terms of law for Native Americans. How do you perceive any effect from that?
Well, why don't you ask the governor of the state of Oklahoma if he is in support of tribal sovereignty? I think that would be a big step if you could see what his response is.
Well, I'll that probably won't be me, but I'm sure someone will pick up the idea. I think I share your belief on that subject. That's all the questions that we have now. There's a question that I think you really answered, so I don't think we need to go back over the one question I see still up. I want to thank you for your contribution, your eloquence and your passion. I mean, this is obviously a vital issue, and it was so kind of you to come and share your knowledge with us.
Thank you very much. I appreciate it.
Ma'am. Okay. Let's see. According to who's our next guy? Andrew Moon is supposed to be next. Is Andrew here?
Good morning, sir. How are you?
It's a pleasure to see you. I was looking at your materials on the VA site. Very nicely done.
Thank you.
For those of you who obviously haven't gone and looked, he has written created a web presentation on suicide prevention for veterans. It is quite well done, and I'm sure he will link to it in his materials. And why don't I let you take it away? You're covering a vital aspect of this. We have got law enforcement, we've done Native Americans, we've talked about the nation as a whole, now veterans.
Sounds good. Thank you, sir. I'm just going to share my screen and get this presentation up. As I am doing that, give me 1 second. Hopefully you all can see that on the screen. Thanks for the introduction. I'm Dr. Andrew Moon. I am actually standing in for Dr. Matthew Miller, who is our Executive Director for Suicide Prevention in VA. I believe he's prepping for a congressional hearing at the moment. So I got tapped to come on and make sure I could impart some knowledge and answer questions that you guys might have around the VA and our efforts and how we work towards suicide prevention for our veterans. So I have a few goals for my presentation. primarily talking about where we get our information, how we have developed the foundation for our plan, for our approach to suicide prevention, and then making sure that we leave you with some of the wonderful resources that we have for our community partners, as well as anyone working within the VA. So as was mentioned earlier, data is a great place to start when we're thinking about health efforts, when we're thinking about public health efforts. And I won't be too redundant in what I share, but understanding that the veteran population, along with many of the other specialty populations that were raised this morning so far, the rate is raising, and it has been raising over the course of the span of time that we've been looking at veteran data specifically. And one of the things that I would point out is that our veteran rate of suicide is actually higher than the general population. It's about 1.5 times higher than their non-veteran counterparts. You may also have seen the number 22 a day, 20 a day, indicating how many veterans die by suicide each day based on these numbers. We've taken some time to adjust that, make sure that those numbers are accurate. And what we can say is that about 17 to 18 veterans die by suicide every day. And I give presentations like this often, and it doesn't get easier to share that piece of information, but definitely keeps us pressed, keeps us moving forward, motivates us to do more and all we can for our veteran population. What I will also point out about that 17 to 18 is that only about 6 of those veterans are actually engaging with VA, VHA healthcare. So we have about 11 veterans who aren't connected to our services, who aren't utilizing our services for whatever reason that may be, whether that's choice or whether they have private insurance. So part of what we'll talk about a little bit later on in the presentation is actually that a lot of our efforts need to be focused outside of the 4 walls of the VA and how we can address those 11 veterans that aren't ever going to see my office as a therapist or their primary care physician in the VA. This was also brought up earlier, which I'm very thankful. This is a topic that's very important across the population, but specifically important for our veterans, and that's lethal means, which, as many of you know, lethal means is the means by which someone dies by suicide and the lethality of those means, and firearms being the most lethal means that could be obtained by someone. And within our veteran population, much like the general rates around suicide, the use of lethal means, specifically firearms, is significantly higher. So with our veterans, the lethal means is firearms about 68.2% of the time, which is about 20 percentage points higher than the general population. And that's across male and female. Our female veterans are also utilizing firearms often as their method of dying by suicide. So lethal means for us is a big push, a big effort to understand how we can make an impact around lethal means. And as was shared earlier, I believe it was Dr. Wakschal, the reason why lethal means is so important is that a suicidal crisis can be very brief. It can be less than 5 minutes. It can be up to an hour. In some cases, around 71% fall within that hour. And what we know is that if we can put time and space between the thought and the action taken when someone dies by suicide, we can likely save a life. We can get them through that suicidal crisis. So a lot of the efforts you'll hear about today are really helping to educate our clinicians, educate the public on this idea of lethal means safety, safe storage of firearms. Particularly important, we don't utilize the terms firearm restriction or removal of firearms. That's not the goal. That's not what we're aiming for. We're aiming for safe storage, anything that can put time and space between, again, that thought and that action, knowing that firearms specifically, if you look to the left of this slide, firearms tend to be more fatal as opposed to some of the other methods people die by suicide. So I just wanted to share those 2 bits of data. We've gotten some great data already, so I won't harp on that too much. And we've heard about these as well, the risk and protective factors. I think it's important when we look at these that we are looking population specific as we work through. So I'm very grateful for Dr. Bigfoot talking specifically about our Native populations and Dr. Wakschal discussing our law enforcement population. All of these are important, and all of them are going to look slightly different based on the population we're trying to address. And a lot of what was discussed is loss and connection, which is a lot of what drives the work that we do for our veterans. So the word I would add into recent loss that hasn't already been said is actually transition. We talk a lot about transition for our veterans, primarily transition from active service to veteran status, which touches on a lot of these items that you see on the screen, which could be mission and purpose. It could be financial changes. It could be unemployment. It definitely changes relationships. And at the core of suicide prevention, as was mentioned, is really the connection. Connection to other people, connection to resources, connection to supports in your life and these protective factors. So one of the things we focus on a lot is understanding that protective factors in a lot of conversations are brought up retroactively, reactively. When someone talks about dying by suicide, we jump to what can we add in for protective factors. But one of the things that I would encourage, especially the individuals on this call, as you're thinking about how you can impact suicide prevention, is to think about protective factors kind of like a daily vitamin. These are things that should be there. These are things that we should shoot for, whether they're someone's in a suicidal crisis or not. These are things that would reduce many public health concerns outside of suicide, but definitely impacting suicide prevention specifically. So taking that data as one source to develop the plan that we're moving forward with in the VA. We also have the VA's National Strategy to Prevent Suicide, which came out in 2018 and does a great job of addressing a lot of the other efforts from our CDC partners and a few other groups. So we have this wonderful tailor-made document for preventing suicide prevention. Along with that, the VA and the Department of Defense publishes clinical guidelines, not just for suicide prevention and risk, they do it for many of the things that we treat both across VA and DoD. But we have one on assessment and management of suicide risk. And what that does a great job of doing, and was recently updated in 2019, what it does a great job of doing is identifying clinical interventions, things that we could employ in a community health clinic, in our hospitals, in our facilities that we know will have a positive impact on suicide prevention. So the most recent one that came out in 2019 focuses strongly on cognitive approaches, cognitive behavioral therapy, problem-solving therapy. But it also talks about some of the other pieces of suicide prevention, particularly crisis response planning or safety planning, universal screening, which is hugely important. I know Dr. Wakschal discussed a little bit about that assessment portion, about understanding, about asking the question. We can't support unless we ask questions directly. So we have all of these great foundational documents, which has built us into this public health strategy. What we know, as I mentioned, is that we have a good number of our veterans that aren't going to be coming into VA care. So we can't just focus on that if we hope to make a dent in those numbers. We have to have a community-based approach paired with this clinically based approach to have a full public health model. What that looks like moving forward, we have a vision for the distance, as it says on the slide. We have a goal over the next 6 years to build up what we're calling Suicide Prevention 2.0, which is that blend of community-based prevention strategies and clinically based strategies. And I'll talk a little about each one of those very quickly. But I will highlight the community-based prevention strategies really are focusing on the connection and on the availability of resources, connection to those resources. So as I mentioned, here are some of the focuses of our community work. The first part of community work when you're trying to address the veteran population is actually understanding if someone identifies as a veteran. Many places aren't asking that question up front, understanding that a veteran population may not always need special or specific attention based on that identity, but they could. And asking the question will help the provider know and address those things as they come up. So one of the big pushes is just helping our healthcare and our community coalitions understanding that identifying someone who identifies as a veteran is particularly important, as well as, again, pushing the risk screening and understanding that everyone can recognize and have a role in suicide prevention. As I mentioned, promoting connectedness and improving care transitions. So I talked about transitions from active duty to veteran status, but there's also a high-risk stage in transition from, say, acute care, inpatient care, into a less stringent care, outpatient mental health, weekly therapy. And one of the things we know is that keeping that constant connection through that transition is particularly helpful in reducing someone's risk for suicide. And then lastly, increasing lethal means safety and safety planning. So again, addressing what we can do to help someone get through that suicidal crisis, that 5 minutes to 1 hour that could potentially save their lives. From the clinical side, one of the things that we're employing is actually a new program, which I was at the forefront of, which is actually building a treatment clinic that is virtual, that will be addressing the needs of our veteran population who have had a suicidal crisis recently, specifically having a suicide attempt, and bringing all of those great clinical practice guidelines in to create a therapeutic situation where someone who is in a more rural area of Oklahoma would have access to this care via telehealth. So we are very excited to be rolling out this program to make sure, again, that we're blending that community approach with the clinical approach. Something else I'd highlight that was part of the clinical practice guidelines, VA has a risk identification strategy, VA Risk ID, and this is actually the largest standardized suicide risk screening in the US, I believe in the world. I'm not so sure on that one, but what it does is it makes sure that anyone coming into the VA will get asked questions to help us identify if risk is present. Regardless of where they're going, who they're seeing, these questions are going to be asked. So again, as was mentioned, we can't address the concerns if we're not asking directly about them. And so we use the CSSRS, the Columbia Screener for Suicide Risk, which is publicly available, a great tool. I know a lot of other groups and state level organizations utilize this. So I'd recommend checking that out if your organization, if your system doesn't already have something in place. Transitioning just slightly, so we have this great 6-year plan, but we know that 6 years is a long way out, and we need to be making strides to prevent suicide more readily. So we have 5 planks to our now plan. Essentially, how are we going to reduce those numbers over the next year, focusing on lethal means? Again, suicide prevention in medical populations, which I know was brought up earlier, how potential negative diagnoses or care through chronic pain, et cetera, is going to impact or exacerbate suicide risk. The other thing we want to do is begin to understand how we can outreach prior VHA users, how we could potentially understand how to make care better and bring them back, or just improve our care in general. I'll show you some slides later as to why that's particularly important. Overall, a suicide prevention program enhancement, we are bulking up. We are making sure we have the resources for everyone. And then a paid media approach, which I can't speak too much about. That would be a whole other presentation, but just making sure that we are making sure that our resources are known and that our efforts are known, and that people can come to the VA for the resources that they need. One more thing that I would highlight as the education and training director of suicide prevention is that education is absolutely an intervention. And one of the things that we are really focused on is making sure that we are building curriculum-based and competency-based education processes. I will also throw in, as we talked a little bit about earlier, special populations, also making sure that our trainings are culturally competent, but also culturally based. So we have a few trainings that are available, VA Save, which is our gatekeeper training. We call that a baseline training that anyone could take for education. And I have some links to these at the end of the slides. But VA Save is actually being worked on by one of my colleagues to be updated and incorporative of culturally appropriate language, whether that is someone who is Spanish speaking or from a Latin country or within our native population. So we aren't going to give the same training because it's not as relevant, it's not as connected. We're not going to be using the terms that resonate in that population. So we're really trying to bridge the gap and make sure we're communicating in a way that is helpful and impactful. We also have some great trainings for our clinicians, trainings in evaluation and management, a great simulation-based training talking about empathy and how to help someone understand their risk level, as well as lethal means safety. If you're not aware, VHA Train is a public-facing training portal that most of our trainings go into so that our community partners can utilize them. So please check that out, especially if you're looking for trainings for your clinicians or for yourself. I mentioned a little earlier about prior VHA users and data being particularly important. I'd also just highlight that in our recent data report, which I put in the chat box, a link to our website, which has our data report and it has state-specific information. Over this last year that we have data for 2017 to 2018, overall, veterans in care with VA had a decline in death by suicide. So something VA is doing is working. And one of the things that we need to do is understand what is working, how are we getting there, what's going to help us move this forward. So a few points around specific populations, diagnoses, et cetera. We've seen some great impact in the care that we're providing. Also an understanding from the ground up and within our organization of that need for community partnership. So I'm trying to rush through to get to time. Resources, very important. Crisis line. If I were doing this live, I would pause and say, please put this in your phone. Particularly helpful, not just for someone in crisis, but if you have a question, a concern, if someone leaves their office and you need to consult, this is a great way of just checking in with what you can do or what you had done. A little bit of more data on the crisis line. Particularly great resource. This is for anyone, not just in the VA. If you are working with a veteran and there is risk involved and you want to talk to someone about what you can do as a clinician, this is an option for you. So shoot them an email. They're very responsive. Let them know who you're working with, what the context is, and they're happy to work through that situation with you. Here's that SAVE training. It's on our PsychArmor website. It's also going to end up on the website I put into the chat box. This is, again, our gatekeeper training that we are encouraging everyone to take so that they can work through the process of identifying signs, asking the question, which was brought up earlier, validating and expediting to care. Make the Connection is a great resource. Veterans telling their own stories about overcoming mental health challenges, about getting connected to care, about what it took for them to move in positive ways. And that is starting, which we don't want it to do. Hopefully, okay, there we go. Coaching into care is another great one, especially if you're working with a veteran who is skeptical about what is out there. And this can help you have those conversations. We have our resource locator that not only works for VA services, but usually works statewide for resources in your area around suicide prevention, very similar to the SPRC that was brought up, which we are big fans of the Suicide Prevention Resource Center. The biggest thing I want to highlight that we haven't talked about just yet is uniting for postvention. So postvention is a term we don't often talk about, that we want to be talking about more, which is this idea that having a loss by suicide, one, puts you at greater risk, but also requires an intervention all in its own, especially from a clinical perspective for providers, for systems, and for family members. So I encourage you to check out United for Suicide Postvention and understand how, if there is a loss, you can be positively impacting the community, your system, each other. Lastly, we're here to support, and we are looking forward to having your support as we move forward. Thank you.
I am deeply impressed by the amount of information. I mean, the sheer volume of it was just like a torrent. And I am delighted with your success. Certainly the statistics seem to show that you are having a positive effect. Congratulations. I'm sorry that the volume of it makes it difficult for me to formulate an intelligent question. There was so much stuff there.
Of course. I'm happy there. We want to cram a lot in. There's a lot there. I'm happy to talk more with anyone on the call about the information. Again, as the education and training person, we create trainings with our partners across the country. We're working with chaplain services. We're working with Custom and Border Protection. We work very stringently to make sure that you guys have the best information and resources possible. So I'll put my contact information in the chat box. If anyone needs anything, I'm happy to support.
We need that. That has been requested many times. I can, on my right side, I can see a half dozen requests for your contact information. So if that, put that in the chat box, that'd be great. I get the impression that these national programs are gradually drifting down to the local areas over the next months.
Yes,
So-
absolutely. That's our plan. We are in the stages of making these national rollouts. We've had some great pilots in a few of our, we call them VISNs, region areas within the VA that have a lot of these initiatives already rolled out, but we're making them national. And so that's been the push the last year and a half.
I am a little bit overwhelmed. I mean, I looked at your website. I had no idea there was this much volume behind it.
Absolutely.
My deepest congratulations on a successful effort. I mean, if people want to tell me the government doesn't work, I'm going to point out your website.
I can also pull up my Outlook calendar to show you the meetings, but no. Thank you for that.
Fine. You persuaded me. I don't need any more. You were a truly wonderful presenter. I think scary amounts of information.
Yeah.
Truly.
Pushed a lot into that one.
That's not a bad thing. But thank you so much. That was wonderful.
Thank you.
Let's see, I believe that the Stephen, is it Grcevich is next?
Grcevich.
Oh, I'm sorry. Yeah, now I was talking to Michael about this earlier, and I was thinking that it might be European, Eastern European.
Croatian. My grand.
Oh, okay, that makes sense.
Mhm.
Does it mean anything?
I'm not sure. I think that it had something to do with my ancestors were bird keepers. So I'd heard it meant something roughly like keeper of the pigeons. So I'm sure they had a messy house.
Well, that sounds great. Now you're going to deal with, we've had suicide dealt with national graphs and information. We know that the scope of the problem, which is huge. And then we went and talked about law enforcement, which has a distinct and difficult problem with it. And then veterans and Native Americans, both of which are groups heavily, but your profession, the ministry, is on the front line of suicide prevention on a kind of I guess it's the skirmish line where you see the individuals.
Well, actually, I have a couple of different professions. My primary profession is that I'm a physician. I'm a child and adolescent psychiatrist. I teach medical students, child psychiatry fellows, had been involved with medication research, looking at safety, side effect issues, and suicide risk with some of the medications that are commonly given to kids. But the reason why I'm here today is that I was invited on behalf of Key Ministry. So I'm board president of an organization. We work with churches around the country and around the world to help them welcome families who have kids with disabilities. And my specific interest or expertise within that is helping churches care for, support, and welcome families who've been impacted by mental illness. So what I'm planning on talking about today is what role churches and religious organizations, pastors can play in helping to prevent suicide and responding to their people in need.
Well, that's a vital aspect, and I'll let you get to it. Thank you so much.
Well, thank you very much. While I'm going ahead and pulling up my slides, I would like to, on behalf of all Clevelanders, to thank the state of Oklahoma for Baker Mayfield. We have suffered through a lot of very bad football here over the years, and being able to watch our team on Sundays is something that we very, very, very much appreciate. So again, thanks to all of you for sending Baker around, and for giving us a little bit of hope on our Sunday afternoons. So it's interesting that I've been involved with Key Ministry, and we've been working with churches now probably close to 20 years. And this is the first time that I was ever asked to speak specifically on the topic of suicide and suicide prevention when it comes to church. A lot of our focus is, again, helping individuals and helping families with mental health struggles connect to church. One of the things that we know from the available research, for example, is that having a child or a teen diagnosed with depression reduces the likelihood of a family setting foot in a church by 72%. There's some data looking at these issues with adults, but the data is not of the same quality as like what we have available to us with kids. So I started like digging around, like, looking for, what the research have to say, and what is there that's out there about like the role that churches and other houses of worship play. I came across this study by, this was done by Lifeway Research about 3.5 years ago. And they did a survey of 1,000 pastors of Protestant churches from across the US. And they surveyed 1,000 adult church members, specifically related to this issue of the church and suicide prevention. And so one of the things that they had found that kind of jumped out at me was that roughly 1/3 of all churchgoers have lost a family member or a close acquaintance to suicide. The most striking statistic, though, and the thing that jumped out at me the most was that when they asked those respondents, like those who had, again, lost a loved one to suicide, a little over 1 in 3 had been actively engaged in attending church at least on a monthly basis, and somewhere between 10 to 18% on a weekly basis, immediately before their death. Yet, even though a significant portion of these folks, were connected with a church or a place of worship, only 4% of the folks surveyed reported that either leaders in the church or other members of the church recognized or had any knowledge or understanding of that individual's struggles and suffering before they died by suicide. Now, when they went ahead and surveyed the pastors in terms of their preparedness for, caring for and supporting folks who were, struggling with suicidal thoughts, well, 80% of them, thought and either strongly agreed or agreed to some extent that their church was prepared to be able to assist someone who was contemplating suicide. Still, if you take a look at the statistics here, there's an awful lot of room for improvement, in terms of the ability of our churches and places of worship to be better prepared to care and support folks when they're having these kinds of struggles. Now, looking throughout the, throughout the literature having to do with like churches, suicide, mental health, one of the threads that connected across different studies is that there's oftentimes a very large disconnect between the perception of pastors and church leaders versus the perception of church members or attendees in terms of how well prepared and how well resourced churches are to be able to care for folks in a time of need. For example, that when they did this survey from Lifeway and they were looking at the data, a little over half of pastors, but only 1 in 6 churchgoers said that their church had an active and current list of mental health professionals who could help to treat someone who is considering suicide. In an earlier survey, this is about 2013, that Lifeway did, specifically looking at issues around serious mental illness in the church. One of the 2 biggest disconnects in the study between pastor perceptions and family members of someone with a severe mental illness was that in that study, 70% of pastors believed they had a current list of mental health professionals who could help someone in a crisis, whereas only 28% of families reported that that was in fact the case. Again, looking at other areas of disconnect, a little less than half of all pastors, but only 1 in 8 churchgoers say that their churches regularly address mental illness. And again, looking at some of this earlier research, when they talked to families of folks who had a severe mental illness, the number one request that they had for their churches was for their pastors to talk about this from the pulpit, because talking about mental health related topics during like worship services goes a very long way in terms of reducing the stigma that still exists, in many different types of churches and many different church traditions around, talking about mental health. Again, that there are more pastors and churchgoers that recognized or believe their church had an active lay counseling ministry. Churchgoers were less likely to be aware that there was a trained counselor or mental health professional on staff at their church where that was the case. And fewer than 1 in 5 pastors, and again, 1 in 8 churchgoers, were aware of their church having any kind of a crisis response team that would include folks who would be available to respond to people experiencing a mental health crisis. Now, so what are some concrete things that we would recommend in terms of action steps, for clergy, like, for, folks within a Christian community, clergy of all faith backgrounds, in order to be better prepared to, to serve their members, attendees, people in the surrounding community who are struggling? So I think that the first point is that in the Lifeway study, I believe that 41% of pastors had reported that they had some sort of formal training in suicide prevention. So that the first piece would be that I think that pastors, along with any frontline staff in churches who are going to be the first point of contact for the public, really should be trained in terms of having a basic understanding and some sort of training in suicide prevention. Now, when we think about some of the changes that have come about in the way churches and other houses of worship do things in an era of COVID, one of the important places to think about, and a category of person who probably needs to be exposed to this training, are folks who are hosts or moderators for online worship services. It's not uncommon at all for folks who are in some sort of a crisis to express that crisis, during some sort of an online worship service or event. And so, I happen to be one of the worship hosts at my own church, and about 2 months ago, we had an 18-year-old start posting messages during one of our worship services describing her crisis. And, we were fortunate that I do what I do for a living and was prepared to be able to respond appropriately. So that, if you've got people, again, representing your church, in terms of like social media platforms, your online worship, the first person who answers the phone when somebody calls, the church. It could be the receptionist who greets people who spontaneously walk in the front door. It would be important for all of those folks to have some basic training in suicide prevention. And it's extraordinarily easy to find this. So that in preparation for this talk, I Googled, pastor training suicide prevention, and within like 60 seconds had several excellent resources. I believe Brandon Johnson's part of this seminar today, and I know that he's been with the Suicide Prevention Resource Center, has some excellent free resources for, any churches, clergy who are interested in learning more about this. I think that the second issue is that it would be incumbent upon anybody, any pastor or clergy member, to become familiar with what the primary local mental health crisis response team is, or place of contact in your city or in your county. And I know that, here in Ohio where I live, that, it's a little different from like county to county. That Cuyahoga County, where Cleveland's based, has a mobile crisis team that will send folks out, that send folks out in the community to, to meet with people in the moment if they're dealing with a crisis like this. The county that I live has a very specific cope line that's tied into our local hospital, that's tied into all of our local mental health resources. So knowing exactly like where to call in your county and where to go and how to engage help when you have someone, who, is experiencing active suicidal ideation or plan would be critically important. I would also add that, it doesn't hurt, again, on your church's website. So for example, if you have a page that has to do with care, support, counseling services, to have the number of the National Suicide Prevention Hotline at the top of the page and readily available, is just one small thing that churches can do to support folks who might be, in a time of need and checking out different resources. The point I touched on earlier, I think, is critically important, that when we go around doing training at different churches in terms of, helping them around developing like a mental health inclusion strategy, one of the things that we very much emphasize is, the importance of, again, church leadership talking about mental health related topics, because it gives folks then permission to be able to talk about this. And you think about that disconnect in the Lifeway study where, 35% of folks who died by suicide were coming to church, but only 4% of them told anybody. Addressing that stigma directly becomes critically important. So interestingly enough, like in our community, there's a church that we worked with that got the award from like our regional NAMI group for cultural competence because of some steps that they took in this arena. And so, some of the types of things that they did, to help people feel more comfortable in their church talking about stuff, and help their people to encourage folks in the local community who are looking for a church but afraid that they won't be accepted or welcome, was for example, this particular church did a fall sermon series on what the Bible and what the Christian faith teaches about anxiety. One of the things, when I was there to do some training with the volunteers who serve their children and teens, was that as part of one of their worship services, they had a little 3-minute video where one of the guys who I believe was like the drummer in their worship band, talked about his own experience with a mental health crisis. There was, we went and it was interesting, we training a very large church in terms of around mental health inclusion. I was sticking around the next day, and their pastor opened the worship service by saying, welcome to all of our guests and visitors who are here. I'd like to start off the service today by praying for anyone who's struggling with depression. Very simple types of interventions like that, again, are steps that you can take that give folks permission to be able to share their burdens with other people in terms of, talking about when there's small groups in the church, being willing to reach out to a pastor or someone who's on a church staff. And then finally, one of the areas, again, that we talked about before, that's an area of disconnect, is that there's no reason why every church or place of worship nowadays can't maintain and update, maybe on a yearly basis or biannual basis, a referral list of mental health practitioners, mental health facilities in their immediate area. But I would encourage anyone who's watching who is, a pastor, anyone who happens to be on staff at a church, that I think it's important that you personally get to know 1 or 2 mental health professionals well enough to send them a text or to pick up the phone and call if you encounter or experience someone who is in the midst of a mental health crisis. Because, one of the things that's oftentimes a frustration to a lot of folks, especially like during this time of COVID, where there's been this enormous spike that we've experienced in mental health needs, is the inability to be able to access timely health, particularly through some of our community systems of care. I know that like part of the way things works, that there are certain, there are certain pastors, there are certain pediatricians, who have my cell phone number. They send me a text, we're going to get somebody in, and get them seen within a day and, begin the process of immediately trying to intervene. So having someone who can kind of help to grease the skids and do what it needs to help people to be able to access care more quickly would be an important resource for anyone, again, any clergy member, anyone serving on staff at a place of worship. So that's pretty much what I have today. If you are involved with a church and interested in learning more about, caring for and supporting folks who may have mental health struggles, our organization, Key Ministry, provides all kinds of free resources and training and consultation. And, we would be happy to come alongside any church that's looking to do a better job, in terms of, serving their people who may be struggling with, suicidal thinking or some sort of mental health crisis, to be able to get hooked up with the care and support that they need. So anyway, I'd like to, again, thank Lee and, thank the folks, for welcoming me today. And I will go ahead and stop at this point and answer and respond to any questions people may have.
There I am. That was wonderful.
Thank you.
A lot of experience. I think that your advice as you closed about knowing a couple of mental health professionals is something every one of us should probably embrace. It's just useful information. Most of us are not trained to handle those kinds of the emergencies that come up sometimes. Let's see. If anyone has a question, fire it off. I'm watching to the right, and I'll see what pops up. Well, I'm getting a lot of thank yous for your presentation.
Yeah, I will go ahead and post a link to the slides and to our other resources in the chat.
Okay, that would be excellent. Did you? Now I'm going to ask a very general question.
Sure.
All of these programs, we've been following this as we deal with different groups in suicidal ideation. Do you have any idea why the rate in your profession, why the rate has increased so dramatically over the last 20 years?
Oh, I think that there are lots of different issues. We know that the rates of mental illness, have increased significantly over the last 20 years, in terms of like what we see with like children and teens. Some of it, I think, has to do with breakdown of like family structure. Trauma is a huge factor here, in terms of like, when we start thinking about, kids and families and their experience of like trauma, abuse, neglect, divorce, abandonment, alcoholism, maybe parents who are less available because of some sort of, mental health crisis of their own, is a contributing factor. Interestingly enough, when we start taking a look at, like, for example, like suicide data in teens, one of the strongest predictors of suicidal behavior is sexual activity. And when I think about this in our practice, for example, probably the most common trigger for a kid having a suicide crisis is when we have kids, particularly if we have kids who are prone toward a lot of obsessive thinking, who become involved with like a sexualized relationship. And when they break up, one of the things that we see is that like a lot of like the kinds of like teenagers I would work with, they don't have the emotional maturity and mental resources to deal with the intensity of emotion that is tied into, to sexual relationships. So if you look at like the National Youth Risk Survey, rates of suicide attempts that result in someone getting medical attention go up incrementally for every sexual contact those teenagers have. You know, and so when I think about that in my line of work, that we're oftentimes kind of pushing kids into situations and into relationships where that their brain just hasn't developed and they don't have the emotional resources to be able to adequately cope.
Well, perhaps satirically, I'm not sure any of us ever quite get as mature as we should be. We do have a question over here about the effect. He wants you to respond to the effect of social media. Okay, I think I think that is a huge issue for vulnerable kids. I didn't get a chance to get to that, and in a couple different ways. One of the things that we know is that the more time kids spend on social media, and prior to COVID, conventional wisdom a year ago seemed to be that once you got up above an hour and a half of screen time, you started seeing kids who had more mental health related issues. And just tying this in like with what other speakers have talked about, one of the things that happens in kids who are like spending like too much time on screens is that it seems to impact their impulse control. And we know that, again, for many folks who make a suicide attempt, as a couple of speakers earlier had talked about, that oftentimes these are, these are kids, in my case, kids acting on very impulsive thoughts. And the extent to which, for example, like, when you start looking at like, how many TikTok followers or Instagram followers you have, the ability of kids to sort of quantify and compare themselves to one another in terms of popularity has been something that, that many of them go ahead and struggle with. The other issue is that, like, when you start thinking about bullying and the level of cruelty has increased exponentially as a result of social media, and folks being able to say really horrible things about one another without being in that person's physical presence, or in many instances knowing them well or knowing them at all. So again, the genie's out of the bag, and I don't think we're going back to a time when we're all going to be using flip phones. And interestingly enough, for a lot of the kids that I work with, social media and electronic communication is like an essential, like, social lifeline for them when they struggle with maybe social communication and picking up on appropriate social interactions. But but parents being aware of this, us trying to monitor their use as much as possible, and being aware of the impact that the social media exposure may be having on their emotions is critical for families, with kids who may be at risk. Well, I see your point. What do you say to parents who say that it's hard to monitor their social media, especially the phones? Well, it's hard to say no to your kid too, and it's hard to keep them from like leaving the house, and drinking or smoking or using illicit drugs. It's hard to go ahead and set limits, but that's part of your job as a parent. And I know our girls, our oldest one's married in medical school, and the youngest one's a senior in college going in the mental health profession. The rule that we had in our house is you can be on social media, we'll go ahead and pay for your phone, but we have the right, at any time to go ahead and inspect it, and if you want us to pay for your cell phone, you're going to let us like look at it if we have reason to believe that we need to. And so, I think, kids need to know that their parents are there to enforce limits too. The parents who just kind of let kids do what they want are more likely to have their kids ending up in my office sitting there talking to me, to be quite honest. So that parents need to to embrace their responsibility as parents and to monitor that part of their child's life the way they would any other part of their child's life. Well, we don't have any, no one has brought up any more questions. I think you fielded my couple quite well. Is there anything you'd like to add? Oh, okay.
Thanks so much for having me. And it's great that you guys are doing this.
I got a question.
Oh,
Let me read it to you. I have a client that is adamant about not going to therapy counseling because it doesn't work. He is sure that a game system is all he needs. What do you think about gaming?
what do I think about gaming? I have I have a fair number of patients, like especially during COVID, where this has been their primary social link to one another. Kids who aren't able to get out of the house because they've had like a family member at risk, in situations where schools have been closed. Again, in moderation, I think that it's something that can be beneficial to kids. But, the ones that I end up talking to are the ones who are spending 6, 8, 10, 12 hours a day who are doing this. I can think of one kid in particular who was gaming 18 hours a day and managed to drop out of college 7 weeks in after having only spoken to 3 people on the campus because they were so preoccupied with gaming and talking to talking to their friends. So, again, for some of our kids, it's a social support. But again, thinking about taking things in moderation, a little bit is fine. When it starts to consume large portions of your day or interferes with the opportunity to actually interact and have relationships in the physical presence of other people, at that point, it's a problem.
I want to thank you very much for your presentation and your willingness to answer questions. Obviously, this comes from years of experience. Thank you so much for helping us out with these matters.
Thank you.
The next is Brandon J. Johnson, who apparently understands the dangers of suicide for young adults.
I do.
Well, we're going to go to senior adults after this, so we're going to cover all the ground possible. I don't, would you like to introduce yourself? I don't have too much information here in front of me.
Sure, I can do that. So thank you all for having me today. So I am Brandon Johnson. I work for the U.S. Department of Health and Human Services in the agency known as SAMHSA, because we love our acronyms. It is the Substance Abuse Mental Health Services Administration. I work particularly in the suicide prevention branch. I have been there for 4 years working on a number of things in our agency. And so I think the floor is mine. So I'll go ahead and move forward.
It's definitely your floor. You got it.
Yep, I'm pulling up the... Got it. Can you all see my screen? We good? All right. So I wanted to start today in going through this with young adults and talking about this issue. I wanted to highlight some data. I'm not going to spend a ton of time on it, just considering I know that others before me have highlighted some data, especially the CDC. So I don't want to spend too much time there. I will add some things from some of SAMHSA's particular data. Then I'm going to look at specifically the risk factors and challenges of our youth and young adults, and then head into some strategies and some resources that we have at SAMHSA to help you all on your way. So let's get to it. So this here and this chart that I wanted to focus here, the first few slides that I'll be showing will be a part of SAMHSA's national survey on drug use and health. And so this survey is conducted by SAMHSA as our data and information. And so I'll walk through things that really coincide with the group that I'll be talking about today. So in looking at this chart, what we're going to see here is, oh, didn't mean to do that, is serious mental illness across different age groups. And so this covers from 2008 to 2019. And so I wanted to particularly look at this young adult age range of 18 to 25. And so I'll be doing some dives into youth, even though Stephen covered a good amount of that just in his questions at the end of his. But I do want to cover and make sure that you all can see where these things intersect. But I wanted to highlight particularly, if you look at the red chart, you can see 3.8% of young adults in 2008 reported a serious mental illness. But if we look at this increase, if you look at that red bar, a dramatic increase, a significant increase from 2008 to 2019. So definitely something that's concerning, a concerning trend. And so I want to pull you over to the right side of the chart also and show that 43.6% of them got no treatment in 2019. That is a startling statistic when we think about that. This is almost half, got no treatment at all. So definitely something that we want to make you all aware of today. So I want to touch on really quickly major depressive episodes for those under 50. If you look at this chart in 2019, you can see one, it's been incrementally increasing from 2016 to 2019. But if you look at 12 to 17 and where ages 18 to 25 are, again, we see these significant increases. We have 3.8 million over in the age range between 12 to 17. And also looking at 18 to 25, we have another 5 million. So we're definitely noticing these high percentages, these trends increasing for mental illnesses, serious mental illnesses, and major depressive episodes, which we all know are risk factors for suicide and suicidal ideation. So again, like I said, I'm not going to focus too much on these. I know this is a chart from CDC. 10 leading cause of death. If we look at the 10 to 24 age range, and I'll talk more about that age range because of something dealing with Samson in a bit. But looking at these young adults is the second leading cause of death within this age group. And so we've still been noticing and seeing, and again, this is CDC data, so thank you, CDC, for this. And looking at that 15 to 24-year-olds, with these suicide rates here, and seeing these, these issues that we've been seeing from 2019 to 2018 as well, and seeing this increase across everyone, but this sharp increase with that young adult age range as well. And so looking at the leading causes of death, this is for our younger folks between 10 to 17. And so I wanted to break this down by racial ethnic groups, just because we're seeing some disturbing trends in some of our subpopulations. And so I know Dee is on and talked about this, but we're seeing high rates, especially from American Indian, Alaska Native populations, as well as our African American youth, are seeing dramatic increases in suicide deaths and attempts in this age range. So definitely something to keep in mind. And as you can see here, where we're seeing those increases take place in American Indian, Alaska Native is definitely an issue, and one that at SAMHSA that we work to address, particularly with some of our grant programs and our funding, which I'll talk about towards the end of this presentation. And so, looking at this as well, and looking at the suicidal thoughts with serious mental illnesses as well, like looking at the serious thoughts in younger adults, in that dramatic increase from 2009 to 2019. Also, in looking at the end of that chart, looking at the attempts that have taken place in those groups as well. So we see these dramatic increases from 2009 to 2019. And so also looking at the intersection of substance use disorder and serious thoughts of suicide plans, and suicide attempts, that there is a connection in that, individuals who are adults and who are engaging and have substance use disorder issues are significantly more likely to have serious thoughts of suicide, to make a plan to end their life, and also to attempt suicide. So it's very important for us to keep in mind those connections and how those things interplay in the work that we do. So I threw a lot of data out and I wanted to move quickly so we could spend more time talking about these risk factors and things that we've seen in research. All of these have, empirical evidence. I could cite a number of articles. If you're looking for information more specific to these things in the work that you're doing, please don't hesitate to reach out to me, and I can connect you with some of the things that I have and that I know, and the studies that I'm aware of, and the work of CDC, some of the work we've seen in NISDA and some other places, and the National Violent Death Reporting System as well, kind of compiled all of these different risk factors. And so as a part of this, I wanted to mention that it's important for us as we engage in suicide prevention, period, across any age group, any specific racial ethnic group, urban versus rural, however we're doing and you're engaged in suicide prevention, having a public health approach and focus, if you are working on the community level, is so important to engaging with individuals at risk for suicide. What we know is that individuals are a part of a number of systems, right? And so looking at the social ecological model, what we know is that we're all individuals. So there's the individual level that we all function, and we all have, successes and challenges and, and issues and assets on the individual level. We also have we also have relationships where people who were on individual and completely isolated, we all have some type of relationship, whether or not they're all positive is another piece, but we all have these relationships, right? And then from there, we're all a part of our community. In some place, community can be a number of different things. It could be geographical location. It could be if you are a veteran, that veteran place that you are is a community, right? And so like we all have community, and then we're all part of a society. We're all a part of the society. It could be regional, it could be local, it could be national, in the world also, as we're all, kind of working to deal with coronavirus. There are some societal things across the world, but it's so important for us to understand where the risk factors are in those four arenas: individual, relational, community, and societal. Because it's so important as a field that we expand from the individual place, which is where we've been for a long time, and kind of think of these things holistically. So as I break down these risk factors, I'm going to break them down by those different areas. Okay. So, all right, let's walk together with this. So individual factors include social demographic characteristics, stressful life events, traumatic life events, which look different for every person, just depending on your life and history and experience and the supports that you have as well. Adverse childhood experiences. We've talked about this so many different times, but there are a number of adverse childhood experiences, such as, a death of a loved one or experiencing abuse and neglect as a child. Also, we're expanding into looking to racism and discrimination as well across groups. Having mental disorders and substance misuse are individual factors that increase risk for suicide in youth and young adults. On the relationship side, child maltreatment, which I just mentioned. Bullying is another one. Bullying is a complex one because there isn't a one-for-one bullying, leads to additional suicides. Usually bullying exacerbates some existing or underlying mental health issues, and also cause traumatic events for youth and young adults as well. And bullying can take a number of forms. It could be in the classroom for younger folks. It could be at home, and it can also be in the workplace for some of our older young adults, if that makes sense. Parental history of suicide and individuals who have lost a parent to suicide. And then parental loss, whether it be death, divorce, etc. There are a number of ways for that to work. Community level risk factors. Being in a rural area, we know that there are challenges with our rural communities in terms of access to resources, in terms of how long it takes to get to a mental health provider, as well. There could be some isolation there. for sure. So social isolation is next. School and work problems are challenges, especially for, we think about our young adults, we think a lot about our college students, high school students. And so school, academic attainment, achievement, all of those things, if not, if not achieved or is trying to be achieved in a toxic way, can exacerbate suicidal thought and ideation. And then we have societal risk factors. So a lack of resources, economic determinants, lack of employment, poor living housing conditions, stigma against help seeking is another one. Not every community and every space feels comfortable going to a mental health provider. So that's something that we all can help change. And I know Stephen talked about the faith piece, which is so important too, because the more we get faith communities to say that this is something that we all should be doing, that we all should have, a counselor or a therapist, or that it's okay to go to one and not a crisis of faith to go to one, helps to break that stigma down for our youth and our young adults. So as we talk about this, what do? We just outlined all these different things. Where do we know best practices are? This is the comprehensive approach to suicide prevention, which was created by the Suicide Prevention Resource Center that I'll go into more details with in a minute. But they are SAMHSA-funded hub for all things suicide prevention. And so with the help of some experts, we created the comprehensive approach to suicide prevention. So for our youth and young adults, I'm going to break down relatively quickly where they fit into each of these pieces of the puzzle for suicide prevention and what we all could be doing to support our youth. Identify and assist. So important for us to understand and know how to identify someone who's at risk for suicide. Suicide screenings are so important. We have the Columbia Suicide Severity Rating Scale, PHQ. Some people use the PHQ-9 as another way to screen, and there are others that I don't have the time to go into. But it's so important in youth serving settings to be trained and understand how to screen for suicide risk, and also for our youth serving agencies who may not have that behavioral health component, to get trained to screen if that's something you're able to do. But if not, to know the warning signs and the risk factors and how to engage a youth that you may feel is suicidal or having some suicidal thoughts. And then knowing what that next step is and making sure that we are following up with our young people. So responding to crises, we all have crises. And I know Stephen talked about his experience, being on church and having a young person reach out and say, I'm in crisis, this is what I'm going through. And he knew what to do. But how do we make sure that others who don't have the clinical training that he has to be able to respond to crisis and assist? Obviously, there's the National Suicide Prevention Lifeline. I'll talk about that more. That's also SAMHSA funded, as well as there's the crisis text line also for youth, and knowing where to refer out if there's a possibility for mobile crisis units in your specific area. Also, crisis intervention teams and law enforcement are critical as well if they're going to go out. I know many places and communities are trying to move away from law enforcement engaging an individual struggling with mental health issues or in mental health crises. But the truth of the matter is that we're far away. We're not there at the point where they won't be involved in the process. And so making sure that a crisis intervention team trained officer is one going out for mental health concerns. Increase help seeking. It can be a struggle for our young people to know or feel comfortable talking about what they're going through, especially to the point that other adults or people close to them have to be involved. For those of us who, we're all teenagers at some point, we know that it can be a time that's isolating because you want to handle things yourself. You want to build that separation from your parents, that you're able to reach out and do those things. So it's so critical to making sure that we're, engaging with our youth and letting them know that it's okay. And even sharing things that we've gone through and helping to normalize what therapy looks like. There are a number of things now. I know we had the discussion on social media. There are a number of resources on social media that specifically talk to break down the stigma and barriers about therapy and other things. I know 1 in 5 is an organization that's based in Cincinnati, they're doing a lot of this work on social media. Psych Hub, a national organization, is doing some of this work to help build these things down. There's therapy for Black girls and Black boys, and also there is man therapy that works on, again, on social media through websites to get people into therapy and kind of demystify it. So it's definitely important for us to do that for our young people, and particularly when we talk about young adults, our college students as well. Postvention is so when an individual, has someone and loses them to suicide, or makes an attempt, how do we then wrap our arms around those individuals? There's some recent data. I do a lot of work with the African American community and young folks who are experiencing suicidal ideation, and how do we work with them? Because some of the data that we've seen very recently from the CDC that's focused on this is that crises preceding, there were crises that preceded a death of a young person, a young African American person, by suicide disproportionately than others. So when these things come up, and when loss happens, and the individual may experience someone losing someone to suicide, what do the supports look like? How do we make sure in our schools, on college campuses, and other places that we're equipped to deal with those? Reducing access to lethal means is always going to be important for our young people, and making sure people are safe with their firearms and have gun locks and things of that nature. Life skills and resilience. Our youth and young adults live more impulsively. Some of our older adults live more impulsively, but they're more likely to, because their brain is not, all the way developed, especially for our younger people. And so it's so important to make sure that they understand how to deal with life's challenges, because we know, as I guess older adults, that that things will happen, things will come up. So how do we make sure that they are okay and equipped to deal with those challenges and be safe and okay? Effective care and treatment, making sure those around the youth are trained and aware of suicide best practices, as well, as another important step there. Care linkages and transitions. This goes to having a referral network. If you are not the person trained or a clinician to do this, making sure that they're connected to individuals who are, or if they need services, as we talk about this comprehensive approach, knowing that people are engaged in other systems. So if you work in a community-based program and there are issues in schools, the kid is going to school, making sure that the school understands and the parents understand how they can be supported in those other areas. For colleges and college campuses, to make sure that they have a referral network, that they make sure that their young people are supported. And the other piece of this is making sure that we follow up with individuals who are found to be at risk for suicide. It's so important for individuals not to get lost in the cracks, not to, for us to reach out and figure out something's going on. We try to help, and we never follow up with that individual. We have so much research that shows the importance of follow-up, whether it be a postcard, whether it be carrying context, whether it be a text, a phone call. Making sure that person is okay is so important. And the last one I'll say is connectedness. We all as humans want to be connected. We all want to be, connected, and, having those positive relationships that can be of comfort to us when we're going through difficult times. Another one, a couple really quickly. It's so important for our youth and young adults to be heard. So I live here in Baltimore, and do work with a number of youth serving organizations, and it's so critical for them to have the piece to share, and that builds help-seeking behavior as well. And so connecting and making sure people are around our youth and young adults. So whether it be mentors, family, clergy, having a licensed clinician, healing circles for individual youth of color is important, and inviting youth into planning activities. If you are at an agency that has influence to build policies and procedures and activities to engage youth and young adults, please make sure they are represented at the table. I do a lot of work with states, and it's so critical that on their advisory boards that there is some youth representation, because you can build the best thing from all of your public health models, your behavioral health know-how, all of these things, and it will not work because it doesn't fit the current state of where youth and young adults are. So definitely a point I wanted to drop there. This I just include because this helps with people always ask, youth and young adults don't want to talk, right? They don't they don't explain things well, or may not have a grasp on their feelings and things. So how do we get them from saying like, are you okay? And them saying we're fine. Or if you're saying, how are you? They're like, oh, we're good. This is a question I got from, this is the chart I got from the Gentle Institute, but it's an emotion and feelings wheel. So asking individuals, like, what are your top 3 emotions that you felt in the past 24, 12, you can make it whatever time distinction that you want. But what it does is that it allows the person to think through their emotions, think through how they're feeling. Instead of getting the one word answer, you may get more information from youth. One of my friends did that to me a while ago, and it stuck with me ever since. And it's worked as I've worked with young adults moving forward. So really quickly, SAMHSA's suicide prevention efforts, the Garrett Lee Smith state, tribal, and campus grants are grants that work closest with youth and young adults between the ages of 10 to 24 to provide suicide prevention strategies for states, tribes, and territories specifically. And I am a government project officer in Garrett Lee Smith, state, tribal, in Zero Suicide, Native Connections, and I oversee as GPO the Suicide Prevention Resource Center, which Dee is the director of. And so we also have our National Action Alliance for Suicide Prevention, which works with a number of public and private sector leaders in reducing suicide prevention. And so I'll put their link in the chat, but it's definitely an organization that I think that individuals should know about, because they're creating a lot of good work coming from that partnership. In the interest of time, I won't go into all of those details. So there's the SPRC, Suicide Prevention Resource Center. I know Dee was on and touched on that. SPRC.org. I encourage you, if you're looking for anything suicide prevention related, a free resource on any population, please check there first, because we probably have it in our resource library. And so that's SAMHSA funded, a $7 million a year grant that we give out every 5 years. And so then there's a National Suicide Prevention Lifeline. The number is still 1-800-273-TALK. I know many of you may be aware of the legislation and things moving forward to change that number to 988. That is still in process. That is not completed yet, but we hope we're marching forward to be able to do that. So definitely wanted to share those as resources. I literally just threw this in the slide because Stephen brought it up earlier, but this is the initiative that he talked about with faith communities called Faith Hope Life. I'm co-lead of this initiative with a professor. My other co-lead is a professor from Eastern Kentucky University. We work with faith communities to provide resources around suicide prevention. We're also, I mentioned it too, because we're working on a toolkit specifically for youth ministries and individuals who work with youth and suicide prevention across a number of faith communities. So we're really excited to get that out. So my sprint is over. This is my contact information. I know that was a lot in a little bit of time. Please follow up with me. I love to connect and talk with people. So if you want more information, want to have more conversations, please reach out to me. My email address is there, and I would love to connect.
Wow. When you started out, it began to connect depression with suicide. I said, oh, we're going to talk about depression and the factors that lead to suicide. And then you went to another factor and then another factor. And by about the 15th factor, I was going, wow, I'm getting kind of overwhelmed. You really covered a lot of ground. In so
hopefully in a good way.
Yeah, well, no, I did not. There was so much to absorb. I do have a question for you.
Sure.
One of the things about the COVID epidemic is that it strikes different communities, Asians, Blacks, Native Americans differently.
Mm-hmm.
And so does suicide. Now, in fact, for white male, suicide is a very high rate.
Mm-hmm.
Do you have any observations that you'd like to share on this?
Yes.
Yeah.
I'm sorry, go ahead.
No, go ahead. I was going to try and confine it a little bit, but I think that I can trust your judgment to run with it.
Okay. So, I mean, so suicide and, with our young people and our young adults, definitely impacting groups in different ways. And, historically and still we see, very high rates among white individuals and American Indian and Alaska Native individuals, for sure, disproportionately. And so there are a number of considerations there. And what we're seeing is that while those are high and we're seeing those rates remain high, is that we're seeing other rates start to creep up incrementally over a period of time. And I think what you could see consistently through the charts that I gave out, like in the beginning, was that, so many of these age ranges and particular racial ethnic groups and even geographical location, like they're increasing across the board. And those who are at higher risk we're already seeing. So looking at our rural communities is so critical to make sure that we have supports in our rural communities for youth and young adults. Considering the lack of resources and the difficulty it is to get to resources is, can be so challenging. And so I think what we're getting to in the field right now in the conversations that we've been having is how do we make sure that suicide prevention doesn't try to be one size fits all. We need some universal, engagement. We need universal interventions and prevention strategies. Those are great. But we also need those who are targeted. We also need those who are culturally specific. We also need ones that work with geographical location. And I think that's where the field is starting to move, right? I was just participated in a report to Congress on African-American youth suicide. And we talked about the differences there and how we address those as well. And we're seeing this with our Korean-American young adults and youth. We're seeing those rates increase. So how do we target specifically those populations? Rural young adult veterans who are still disproportionately impacted. And I know it was a great presentation before this around that. But how do we make sure that we are actively studying the trends, and seeing where we are, and how do we start to curb and make those things, and get that overall rate down? I hope that answered your question.
No, absolutely. I mean, what you're describing is a challenging environment that varies from place to place, locale to locale, group by group, and you can't have a simple approach to it. It requires complexity, judgment, and intelligent decision making, and something that our society is sometimes a little short of.
Sure.
Thank you so much for your presentation. I think that we could have had you on alone to do a 3-hour and get slides, and given you a little time to develop your thesis. It would have been, you could have done the whole thing. Lots of stuff.
Thank you. I appreciate this event has been awesome, and I appreciate being invited to be here.
I could see you could talk for 25 minutes about the bullying aspect by itself. I mean, I could see that. But there just wasn't any opportunity. So perhaps another time. And
Sure.
Thank you for sharing your great learning with us. It's very kind.
Thank you. Great to meet you also.
Sir. Well, the next presenter and our last presenter is William Durick, who's supposed to talk about senior adults. Hey, William. Is it okay to call you William? Mr. Durick, can you hear me? Mr. Durick, how are you doing?
I'm doing good. Are you hear me?
We're trying to get you up. Mr. Durick, your topic is senior adults, which is the last area that we have to cover. I was looking you up on the internet to get some background information. You wouldn't happen to have some relatives in the medical profession, would you?
Now, can you hear me?
A little bit.
Okay. That help? That
Let me
help
send
at
a
all?
message to Michael.
Huh?
Oh, there you go.
Okay,
Now we got it.
okay.
Anyway, I found a number of doctors with your last name in the area. So,
Well, I feel out of place with this presentation because it's my, can you hear me?
you're a little low.
Can you hear me now?
Better, yes.
Say, I feel out of place with it. But my observation is all observational. It's not scientific.
Well, there's certainly time for that.
Right?
That is certainly an important point of view to bring it up from observation as well as scientific.
Well,
We're not creatures purely of fact.
you know, my background is internal medicine, and the last 20 years of my practice was in geriatrics at Claremont. You hear me?
You're very low.
Well, I don't know what I can do to increase that. Does that help at all? That
No.
help at all?
Not that I can tell.
I don't know what else I can do.
That is, you do sound better now.
Okay. They tried something else there. Anyway, I practiced geriatric medicine at Claremont for the last 20 years. I retired in 2014. And my observation has been what happens to the elderly after they retire. And they become isolated because they have several reasons for that. Number one, they quickly have lost a spouse, so they are, it looks like they lost it.
You're still broadcasting.
What?
Well,
Are you still there? Okay. Anyway, what I noticed is that the patients who come as they enter retirement, they have the idea of, well, we're going to do all these things during retirement, and all of a sudden they don't have the energy to do it. And so then they lose their spouse, and then they don't fit with the group because everybody else is couples, and then they become more and more isolated because they're not out there intermingling with the rest of the group. And then so they're primarily at home, nobody's looking in on them, and they lose some hearing, they lose some eyesight, and then they become more isolated. And then they do have the potential for suicide, and they have the means and that most of them are taking medications, and if they're knowledgeable, they can choose the medication that will can reduce suicide. So they become more and more isolated, more and more lonely, and nobody's actually looking in on them. The family structure has broken down, so the family's not taking care of them. And then the family discovers, oh my gosh, we've got to do something about this. And so what do? They consider a long-term facility. Okay, what happens in the long-term facility? They becomes worse because long-term facility is worried that the potential for lawsuits and so forth if the patient falls. So we'll keep him care fast or bed fast, and then we won't have that risk. Well, what happens is he becomes more isolated and more at potential for suicide. So here we have a whole group of people that are at high potential because of the situation. And I can relate that there is interventions that could have been taken. I can tell you about my personal experience here with my father. And my father was at home in a small community in eastern South Dakota. And when my mother died, he stayed in the home and continued to want to be active. He did very well. Unfortunately, the community had a law enforcement had intervention there that the sheriff's department in the county kept a list of all the people that were homebound and called them each morning to see if they were all right. That's not very practical in most places, but it worked there. Then she finally had to enter a nursing home, and the nursing home tended to break the rules because he had friends that would come by, pick him up, they'd go down to the local cafe, have coffee, get him involved in some of the local activities, and this went on several times a week. And so he had an excellent situation. But that's not what's occurring now. And now they become more and more isolated, more and more away from society, and they don't have the old structures of family and so forth to support them. They an interesting finding I did note recently, an article that family support was much more evident in the Latino communities, and they had a lower suicide rate, which I wish I could tell you the exact source of that, but I couldn't. But anyway, so these are the things that are happening, and I think we need to look at that elderly group and be sure that we reach out to them.
Well, you're describing a kind of a vicious cycle where people, once they become a certain age, become more and more isolated by their physical infirmities and societal beliefs.
Yeah.
Of course, the pandemic certainly hadn't helped that.
And I don't think there's any community services that reach out to this group. They work out the other groups, but they kind of leave the elderly out if if they need to reach out to the elderly, think of long-term care or something like that. And to me, that's not the answer.
What do you think the answer is?
I think community involvement, family involvement is the answer. We need to get these people involved. And to do that, you have to recognize the limitations, such as hearing and eyesight and so forth. But we need to get them involved.
Do you think that some misuse of prescription drugs is considered accidents rather than suicide?
I think prescription drugs is the source that they use for suicide. And I personally, in my own experience as a geriatric doctor, I think we prescribe far too many medications to this group.
I've seen elderly people with 15 or 16 prescriptions.
That's right. And anytime you get over 4, you've got problems.
I think you're right. Probably more than 4 or 5 is probably just going, you can't figure the side effects.
Yeah. Anytime you get over 4, you need to be looking at it to see if you need those drugs.
So do you consider this a national crisis, the way old people are dealing with, being dealt with now?
I think it is going to be a national crisis because we're going to see more elderly as the groups of elderly with the baby group enter this age group.
Do you have anything you want to add? I think you've made your point.
Yeah, I think this is my point, and I realize this isn't scientifically based, but it certainly is observational based.
Well, you know, you closed us out at a vital point because the elderly were the last large group we hadn't discussed, and you brought insight to a difficult subject, and I appreciate it.
Okay, well, I enjoyed the session. Thank you.
You have a wonderful day, and I thank you so much for spending your time with us.
Okay, thank you.
That is the last of our presenters. We're going to have more time for more questions, but we kind of ran over. So if you would like to get your CEUs, I put my email up several times. Send them to my email. I already went and checked my email. There's quite a number of people in there requesting their CEU credits. So the email's working fine. southwork@gmail.com. I'm told that you get 2 CEUs, but some people have told me they were supposed to get 5. I will check and see if there are more, but I am told 2 at this time. I want to thank everybody again for their work and presentations. I am amazed at how much information we covered in a relatively short period of time. Is there anybody who has any final thoughts they'd like to add? Someone has said it's supposed to go till 2 p.m. My sheet shows it ends at noon.